Hello and welcome to Clean Talk. I'm your host, Brad Whitchurch. It is Wednesday, September 7th at 3 p.m. Eastern Time, and that means we are coming to you live from the beautiful Seal Shield Studios here in downtown Orlando, Florida. Very excited to have our guest today. He is a medical rock star and a healthcare hero. We're very proud to have on our show today Dr. Tom Balcezak. He's the Chief Clinical Officer at Yale New Haven Health System. Tom, welcome to the show.
Thank you, Brad. It's a pleasure to be here. I'm coming to you from downtown New Haven, where the weather isn't so perfect right now. It's a little gray, and we just got through about 5 inches of rain, but it's still summer, so that's great.
Well, it is hot here, and we're looking forward to the rain this afternoon, but we are really looking forward to diving into it with you today here, Tom. Really excited to have you on the show. For our audience, can you tell us a little bit about your background and from your perspective, why you're on Clean Talk today?
Sure. So as you mentioned, I'm a physician. I'm an internist. I had a sort of a career change right after my finishing of my residency. That is my postgraduate training, for a variety of reasons. One of which was a book that was published in 1999 called "To Err is Human" by the Institute of Medicine. I decided I was going to devote my career to quality improvement and trying to do sort of macro scale improvements at a health system and a hospital level so that patients got the best care. Long story behind that, but I really enjoyed my medical training. I really enjoyed learning physiology and pathophysiology and making a difference in people's lives. And this was an opportunity for me to do so at a much broader and grander scale.
Well, you're setting me up here, Tom, because I'm always curious when I talk to successful people, what the path entailed. You obviously devoted a lot of energy to your medical studies, to your to going to medical school, the residency, and then how does that transition, as you said, to changing to moving into administration, and how do you balance the healthcare of individuals and the leadership in an organization? How do you get there, and how do you make that work?
It's funny. I think right now where I sit in retrospect, I've been here now 30 years. In retrospect, it's absolutely crystal clear how I got here. But if you had asked me along the way, or asked me 30 years ago how it was that I got interested in quality improvement and improving systems, I probably wouldn't have been able to articulate it. And my wife and I have sort of deconstructed our lives in retrospect and how we got to where we were. And I think it really came down to two things. One is, who hasn't been part of a system when you're a cog in the wheel and has said to themselves, look, we could do this better. There's ways that we can make things better. Why are we doing it this way? Why don't we change? And when I was a resident, I certainly was in that position. And then we had an experience, my wife and I had an experience where we were working in Africa. We were in Tanzania for a couple of months working at a hospital as part of our residency rotations. And we worked there for 2 months. And the day we arrived, the head of the hospital went on vacation for 2 weeks and essentially turned this 75-bed hospital over to my wife and I and asked us to run it while he was away on vacation, which for a 27-year-old kid was pretty staggering amount of responsibility. But yet we had a great team around us. And despite having electricity only 4 or 5 hours a day and only a handful of lab tests, we had some really ingenious individuals that figured out how to do medical care at a different scale and really MacGyver some programs together. And we walked away from that experience with two very different conclusions. One, my wife changed her career and went into the acute side of medicine, emergency medicine. And I said, look, if they can do this kind of really amazing amount of quality improvement with virtually no resources, then we should be able to do much, much more with the resources we have. So when I came back from that experience and finished my residency, I took an opportunity to work with one of the senior physician leaders at the hospital at the time and do some early quality improvement work. And then I just sort of built my knowledge base. I got a master's degree in public health, and really sort of dedicated my life and dedicated my career to trying to make the systems of care, the quality of care better within our organization. And that sort of just built one step or one block on another to put me in my current role today.
I love how you have that perspective on resource allocation. Obviously, a big issue in the healthcare systems. We're going to get to that. But first, for our audience, can you tell us a little bit about your health system, Yale New Haven Health System, near and dear to our heart here? But for our audience, tell us a little bit about Yale New Haven.
Sure. So our name gives us away. We're located, our flagship is the Yale New Haven Hospital in New Haven, Connecticut. That's our academic medical center. Of course, we're partners with the Yale School of Medicine and the Yale Medicine faculty. Here in New Haven, we have about 1,500 beds at our academic medical center, which makes us one of the top 5 sized hospitals in the United States. But as a health system, we're really a moderate sized health system. Our geography is the 100 miles, that's the coastline of Connecticut. We hug the coast and we go from New York State, a little bit of entree into New York, into Westerly, Rhode Island. We have 7 campuses, 5 hospitals. We have about 30,000 employees and about $6 billion in annual revenue, and about 2,600 total beds across our health system, with about 6,000 physicians as part of our medical staffs.
That's a long way from the 75-bed hospital in Africa. What are the challenges or maybe the benefits of operating in a healthcare system versus an individual hospital? What can you share with us about that?
Well, that's a really good question. And there's a debate nationally about how big is too big. What are the benefits of a health system? And I think, the COVID pandemic, I think, has been one of the most recent events that have pointed out the benefits of being a health system. We certainly felt that here in Connecticut. Being in Connecticut with its proximity to Manhattan, we felt the effects of COVID very early in March of 2020. And that we saw the cases creeping up from New York, when everyone knows that the real epicenter at the beginning, right after the West Coast outbreak, was the East Coast outbreak in Manhattan. And we felt that in Greenwich Hospital. And we were able to load distribute early on and bring resources down to Greenwich Hospital and bring patients up from Greenwich Hospital and really prevent a catastrophic collapse of that institution. Because we were a health system, because we could load balance and float staff and technology and resources down to them and balance patients. And there are other hospitals within our state that are not part of a health system. And we actually ended up stepping in and helping them in a very similar way. But because we were a health system, we were very rapidly able to step in and help them and pivot and allow them to continue to deliver care. But that goes on not just during the pandemic. That happens all the time. And right now we're doing this work that we're really excited about that we call Care Signature, which is really the idea that if you go into any of our institutions, any of the places where we deliver care under our umbrella, that you should be expecting the same high quality care and consistent care no matter where you go. And the way you do that is by making sure you've got the same processes, the same technology, the same training, same pathways. And that's really important to us, that it's not just at the academic medical center where you can expect cutting edge care, but we are connected in a way that you can deliver that cutting edge care everywhere. And while we don't do, for example, kidney transplants at all of our institutions, you should get into that funnel if you need one and be referred in a seamless way to the academic medical center where you can get one, regardless of where you initially present. And that's, I think, one of the values of being an integrated health system. And of course, there are lots of others. I mean, there's always the back office functions, billing, collecting, human resources, marketing, that certainly you get value from scale. But also on the clinical side, we believe that there's a huge opportunity to continue to improve the quality of care and drive it in a consistent fashion that I described.
So consistent care across the system, but access to specialist facilities for specialist activities.
Exactly. I mean, for example, there's been huge improvements in the care of patients that have stroke. Well, no matter where you go in our health system, you will have a consistent approach to how stroke care is taken care of, because we have telestroke services in all of our emergency department, meaning while we don't have individual neurosurgeons that can extract clots from brains in every one of our delivery networks, every one of our hospitals, we have neurologists that use telehealth services in our emergency departments, assess patients, treat them safely if they can be treated safely in that organization, But if they need advanced services, if they need to have a neurosurgeon extract a clot, they can rapidly refer that patient to one of our institutions that has that capability, and make sure that no matter where you go within the Yale New Haven Health System, it shouldn't matter where you are, but because you're in our health system, you should be assured that you get the same high quality care no matter where you go.
Well, you mentioned the benefit of having the healthcare system during COVID to be able to manage the patient load. Obviously, we all know, everyone watching this podcast, either firsthand or anecdotally, the challenges that healthcare has faced during the COVID pandemic. What are some of the other challenges that Yale New Haven had to deal with, and have some of those solutions or evolved practices persisted?
Yes, I mean, absolutely yes. First of all, some of the challenges, I think secular trends that have been happening within healthcare have been accelerated, meaning, we knew that there was going to be a coming crisis in terms of staffing. And I think, with the past couple of months and the great resignation that's happened, it certainly impacted us. So we have been figuring out ways how to do more with less. Staff are now finding themselves able to work remotely within job categories that we never were able to work remotely before. And that's helped us in the staffing models. It's certainly, I think, helped staff that want to have hybrid jobs where, because of personal circumstances, they can't be in hospital or in one of our buildings, and they work from home. We've also seen challenges in supply chain, just like we've seen in all of our grocery stores and other kinds of stores. We find it difficult on a daily basis, depending on the day or the month, to source specific types of equipment. The old N95 masks that you saw so frequently during the COVID pandemic, we used to buy them for around 50 cents a piece. At the height of the pandemic, they were costing us $9 a piece, and that's persisted. So just like pretty much every other sector of the economy or our lives, whether it be staffing or supply chain or cost of product, we've seen those same sorts of challenges. And I think that we've had to pivot and change how we approach each one of those to make sure that we can continue to deliver high quality care.
Sure. And of course, many of those challenges still exist. But were there some silver linings? You had mentioned the telehealth initiatives at Yale New Haven. We've seen a huge, let's say COVID was a catalyst for this technology that's been around for a while, but really COVID, I think, was a catalyst to push it forward and has really made it more mainstream. And I think providing potentially better outcomes for patients. Would you agree with that? And are there other technologies, other silver linings that you've seen as a result of COVID that make us better moving forward?
Yeah, no, it's hard. It's hard to say that a pandemic that's killed over 1 million people has silver lining, but it is true. There have been some changes that I think that have been catalyzed by the COVID pandemic that I think on balance make us stronger and make our healthcare systems better. I think telehealth, you're absolutely right. We now are able to do telehealth visits on a regular basis, and we are much more efficient at doing them. And I think the populations are much more comfortable doing telehealth. We built about 10 years ago a tele-ICU. So we were able to have remote monitoring in all of our ICUs by a bunker here that's staffed by intensivists and nurses. And there's no doubt that that has improved care. We made a decision at the height of the pandemic, when we were really seeing lots of patients, that we would transfer no ICU patients to the academic medical center in New Haven, except if they needed heart-lung bypass machine, ECMO services. And so we had this sort of shelter in place. But what that required us to do was to provide increased staffing at all of the outlying ICUs within our health system. And you can't create more critical care doctors. So what we did is we used telehealth services to leverage their expertise at each one of those hospitals, and we did it remotely. And when you looked back at our mortality rate, it was the same in every one of our ICUs. There was no difference among those patients who survived or died based on what location they walked into. So for us, that was really, I think, an affirmation of how our care signature work can roll out to ensure that we have the same high quality care everywhere. And because the knowledge about how to treat COVID was rapidly changing. I mean, we were literally changing our care protocols once or twice a week. And then we rolled them out to all of our physicians, all of our ICUs and floors. And there was absolute pickup within those next 24 hours. It was a way for us to really reinforce how we believe care signature should evolve. Knowledge in healthcare is doubling at a staggering rate. In 1950, knowledge doubled every 50 years. In 2010, knowledge in healthcare doubled every 3.5 years. Wow. In 2020, that was down to 73 days. Now, nobody, no matter how much you read, no matter how much you study, how many courses you go to, nobody can keep up with that.
You can't stay ahead of the curve.
You can't. And so you have to use technology as a way to stay ahead of that. And, the rapid increase in knowledge of how to treat COVID, that was something that I think really brought people around to being much, much more accepting of prompts and checklists and reminders, and using our electronic systems to be able to help people, incorporate that new knowledge as it evolved into their clinical practice.
And let's talk a little bit about that technology. We talked about telehealth, but the incredible advancements in remote monitoring systems to provide quality home health care. Can you talk a little bit about what Yale New Haven is doing in that regard?
Yeah, that's another area that's really rapidly progressing, and probably another one of those silver linings of COVID. When the public health emergency around COVID was declared, a lot of regulations were eased. Some regulations were passed that allowed us to do things we couldn't do in the past. And the Center for Medicare Services allowed for us to apply for a waiver to provide hospital level services in people's homes. And so in the fall of 2021, we applied for and received that waiver. So we are now providing hospital level services in people's homes using a little suitcase that contains a blood pressure cuff, an oxygen saturation monitor, some other technology, and then a cellular enabled, essentially an iPad that allows us to bring our nurses, our other caregivers directly into those people's homes. And then we send out pharmacists and phlebotomists and physicians and nurses to do assessments in those people's homes. And we admitted our first patient back in June. And we're now carrying a small average daily census of between 3 and 5. But we anticipate as many as 25% of all patients that are hospitalized today could someday be hospitalized in their own home. And we bring those services to them. And just think about the benefits of that. I mean, think about the benefits of having a home cooked meal, the benefits of getting better rest when you're sleeping in your own bed, having your family around you. That's personal benefits. And we think so far, in our experience, mirrors that of many others that are doing what we're doing, is we can do it safely and at a much lower price point, saving money for the ultimate consumer, the people who we're caring for.
Absolutely more convenient for the healthcare patient, and certainly more efficient for the healthcare practitioner. And with the technology providing similar or even preferable outcomes, it's just a win all around. What can you tell us about other technology being implemented in healthcare today, and how you balance the need for emerging technology and the need to maintain cost controls? You've talked about some of the supply chain issues and resulting pricing issues. How do you perform that balance of keeping costs low for the consumer while always being on the cutting edge of emerging technology?
That's a really tough question, because in virtually every other segment of the economy, technology has improved the consumer's experience while simultaneously bringing costs down. I mean, think about the automobiles you drive. I mean, today, every car comes with electric windows and air conditioning and multiple cup holders and better gas mileage and the safety features. I mean, you wouldn't think about putting any of your loved ones in a car that didn't have anti-lock brakes and at least 6 or 7 airbags. I mean, think about all the technological improvements that you have in automobiles today. And yet, inflation adjusted, cars are cheaper now than they really have ever been. And they last longer. Well, I wish the same could be said for healthcare. I mean, every instance of technology that we see elevates the cost of care. And I think we have a national challenge right now in trying to think about how we can use technology to lower the cost of care. Now, it's unarguable that the quality of care and outcomes have improved. People say that America has the best sick care system in the world, and I fully agree with that. If you have a serious illness or chronic illness and you have resources, there's no other place you want to be other than the United States. However, on a global scale, as evidenced by the fact that, our lifespan has fallen over these last 3 years, we don't provide primary care, we don't provide access to care, we don't provide chronic care, as well as many other parts of the world. And there's lots of reasons for that. But what we can and should be working on is how to lower the barriers to accessibility, the barriers to primary care, and overall total cost. How we do that, that's a subject of a much longer discussion, but it's a real challenge, I think, for everyone. No matter what part of the healthcare space you're in, we should be looking at how we don't continue to be the gross domestic product hog that we are. I mean, look, 18% of our GDP is now wrapped up some other way in healthcare, and we should be figuring out how we don't squeeze out housing and education, and all those other important things that are in our gross domestic product.
Absolutely. The goal is to lower the cost and improve the outcomes. I have to ask you, though, Tom, we are an infection control podcast here at Clean Talk. And of course, we monitor very closely hospital-acquired infections, and we've been making a lot of progress on hospital-acquired infections, particularly over the last decade. And yet, as I know you're aware, in this COVID pandemic world that we live in, for the first time in a long time, we've seen hospital-acquired infections start to inch up. To what do you attribute that, and what can we do about it?
Another great question. When I think about hospital-acquired infections, I can't not think about my training. When I trained here, it was always, the expectation that, hospital-acquired infections, well, they're the cost of doing business. They just happen. And we didn't have reliable ways of measuring, tracking, certainly didn't have reliable ways of preventing. And you fast forward now 30 years later, our mindset has completely changed. Zero is our target. Nothing other than zero hospital-acquired infections is acceptable. And as you said, we've really made, as a nation, as a world, remarkable progress in being able to reduce those. Why is it bumped up again? That's a great question. Longer lengths of stay, sicker patients, perhaps taking our eye off the ball a little bit, because we're functioning with different staffing levels, trying to sort out a new pandemic disease that's impacted all of us. And I think during the pandemic, we did see an uptick slightly in some of the hospital-acquired infections, but we've seen that number recently very rapidly come back down as we've resumed normal operations. And I think you're absolutely right. I think we've made remarkable progress, and I think that will only continue. And things like hospital at home, as we get people deinstitutionalized, I think those kinds of things will continue to help. We certainly know that one of the risk factors of a hospital-acquired infection is being in the hospital. Getting people home sooner, shorter lengths of stay, perhaps lengths of stay in the hospital of zero, that can only help us.
Yeah, I agree. And of course, that also contributes to reducing costs if we can have control over hospital-acquired infections. Let's stay on the topic of technology. What is the EICU at Yale New Haven? I'm asking for a friend.
So the EICU was built by a whole bunch of very clever people within our health system. So we happen to be on one of the two large information systems. Our information system that we do all of our ordering and note writing and thing is Epic. And we looked at some commercial products to do an EICU where we would monitor patients with both a video camera, but also look at their vital signs and be able to have at a distance critical care physicians and nurses and others, respiratory therapists, evaluate what's going on at a critical care patient's bedside at a distance about a decade ago. And our folks in information technology, our ICU leaders, our nursing leaders, respiratory therapy leaders, put it all together and built it homegrown, if you will, inside of our electronic medical record. That's the Epic medical record. And it works great. And it really saved our bacon during COVID, as I mentioned earlier. And I think it's really improved the quality of care in all of our ICUs across all of our campuses. It's been, I think, for us, a continued success and really proof of concept that there are areas where we can use technology. We can leverage existing technology to improve care and lower total costs. I mean, think about it. If you're monitoring a patient that is 60, 70 miles away, you can reduce the staffing in that ICU and simultaneously improve how much monitoring you're able to do, because you've got the continuous reading of that person's vital signs. You've got a continuous eye on them via the camera. And we use some internally built algorithms so to make sure that the patients that are having deterioration or the patients that have the most tenuous vital signs are the ones that are most rapidly evaluated and most frequently looked at by our critical care team.
That's outstanding. Dr. Tom, I'd like to take a second. We've got a couple of questions from our audience. Jordan asks, and I promise we're not a political show. Jordan asks, what is Tom's opinion on the fact that people are still dying from a virus that we have a vaccination for? Is the virus mutating so quickly that it is not possible to create vaccinations fast enough? How would you answer her question?
A couple things. One is there will always people be dying of diseases for which there is a vaccine. Look at flu, for example. Flu has about 0.1% mortality rate. When COVID first hit in the United States, the mortality rate was about 1%, or 10 times the mortality rate of flu. That mortality rate has fallen right now across the United States, across all of our population, to about 0.3%. So it's not quite where flu is, but it's getting close. The more of the population that becomes vaccinated, the closer we'll fall to being the flu-like mortality rate. Vaccines work, there's no question. It's been the biggest impact, it has had the biggest impact on mortality across the United States. Folks, I encourage people to get vaccinated. The vaccine is safe, it's effective, and you just heard that the new bivalent vaccine's been approved, and that'll be rolling out, started last week, and by the fall will be in full rollout. I will predict that there's going to be a seasonality to this, like there is to flu. And for those of us who go and get the flu vaccine every fall, it's going to be likely that we'll be getting a flu vaccine, and at some point, a flu vaccine that is either paired with or combined with a COVID vaccine. There's only been one disease in human history that's been eliminated, and that's been smallpox. So now that COVID is in our population, I don't anticipate it'll ever leave, and we're just going to need to learn to live with it and reduce its impact.
Get vaccinated.
Get vaccinated.
Thank you for that.
Yeah, no, and then look, you guys are heavily focused on infection prevention, and vaccine is in that realm. It is an infection prevention.
Absolutely.
We're here very close to Rockland County. I think most of your listeners probably know that there have been no cases of polio in the United States for many, many years, to the point where there's 2 polio vaccines. There's a inactivated and a completely dead vaccine. We only use the dead vaccine in the United States. Unfortunately, someone was abroad and was exposed to the inactivated vaccine, which can reactivate in rare cases. This person was unvaccinated, contracted polio abroad and brought it back, and it's now been circulating, and you can find it in the wastewater in Rockland County, New York. The population of Rockland County is not very highly vaccinated in polio. So the first time in, more than 30 years, we may start seeing more polio outbreaks in the United States. And for those of you who are in the infectious disease world, know that we were on the cusp of completely eliminating polio in the world. Unfortunately, we just took a giant step backwards on that. And it's all because we don't have a highly vaccinated population.
That is unfortunate. And of course, it is inevitable that there will be other epidemics. And as we can see, even the epidemics that we've gotten under control, we always have to be cautious and mindful that if we're not taking the proper precautions, they can come back. Thank you for that update on polio. I know that's interesting to our audience. Tom, we do have one other question. This one comes from across the pond over in Europe. An international viewer, Oliver, asks, lower the cost is certainly a great goal, but also accessibility, regardless of income, should be researched not only in the US, but even here in Europe, where in general accessibility is wider. What about this social issue, right? In the United States, we have our system. As you said, if you have access to the care, if you have the financial access, the best sick care you're going to get in the world is in the United States. Is there something we can do better about making care more affordable outside of income restraints?
Great questions. In most of the Western democracies, from your, from your questioner's perspective, of course, most of the Western democracies do better in terms of access to basic preventative care. And when I say basic preventative care, I don't just simply mean medical care, but the social aspects of life: healthy food, housing, education. Those social determinants make a big difference in people's lifespan. One of my colleagues and friends, Dr. Betsy Bradley, who was for a long time here at the School of Public Health, wrote a really interesting book looking at social welfare spending combined with medical spending across the United States and compared to other democracies across the world. And basically what she showed was that if you simply look at medical spending, we outpace the world. But if you combine medical spending with social welfare spending, we're about middle of the pack. And I think we need to start thinking about how we look at healthcare spending. We medicalize lots of the social ills, whether it be substance abuse or mental health challenges. And a lot of that can be helped by improving our social safety net. And I think that we need to start thinking about that differently if we're going to truly make access to care and holistic health care more affordable and more accessible.
That is a great perspective. And I'm going to put you on the spot here, Tom. You're at the top of the mountain at Yale New Haven Health System as the chief clinical officer. If there is one thing you could change, what would it be?
Well, globally, I would pick up on that theme that we were just talking about. I mean, I think globally, what I think we need to do is think more holistically about what constitutes health. Health is everything from access to education to housing and all the social welfare determinants of health are important in determining people's health. And I think that we should be looking at how we can begin to reduce some of our spending in some of our acute care services and bring it over to make it more accessible and affordable and try to improve the lives of folks that have difficult social determinant challenges. And I think that'll have a meaningful impact in the health of our country.
That's a terrific goal. Tom, in closing, what predictions for the future?
I think predictions for the future are that we are going to continue to lead the world in scientific advancement, in healthcare advancement. I think we're going to take more steps in trying to improve access and affordability. I think the pressure on providers like us is going to continue to bring healthcare costs down. We are going to need partners in trying to do that. I think we're going to need to look to our local and state and federal governments to partner around those things. That's one prediction. Two prediction is COVID is going to be with us and become a seasonal disease. And as we continue to improve treatments, as we get more refinement in our vaccines, it's going to become a slight annoyance and much less deadly than it currently is. And it's going to become more like flu. And I think we're going to continue to see movement into telehealth and more remote accessibility. And hopefully that's going to also improve access in healthcare.
I can't argue with any of that. I concur. Our guest today has been Dr. Tom Balcezak. Tom, if people want to find out more about Yale New Haven Health or some of the things we're talking about, what should they do?
Well, of course, you can go on our website, and that's probably the best place to go. And I think that there's a lot of information there about us and about Yale New Haven. And of course, if people want to reach out directly to me, I'm happy to have a conversation.
I really appreciate your time today. I know you're a busy guy. I know our audience appreciated you coming on today. Thank you for being a part of our show. And thank you all for watching Clean Talk today. Be sure to join us next week, Wednesday at 3 p.m. Eastern Time. We'll be coming to you live. Until then, for my guest, Dr. Tom Balcezak, I'm your host, Brad Whitchurch, reminding you to keep it clean.